para o próximo painel. Eu vou só checar aqui se nós já estamos sendo transmitidos no YouTube. Eu acredito que sim, porque o nosso próximo painel é um painel aberto, o painel internacional. Nós ficamos muito contentes com a confirmação, né, a participação agora de lideranças internacionais, e para isso eu convido o nosso parceiro já de muitos anos de Fórum, Diogo Alves, que é consultor nacional da Organização Pan-Americana da Saúde e também é facilitador do nosso GT de prevenção de DCNTs aqui dentro do fórum. O Diogo vai, então, fazer toda a moderação desse painel, lembrando que ele é um painel conduzido em inglês, visto que são os nossos convidados, os nossos panelistas, são de diferentes países, são panelistas internacionais que vão trazer aqui essa perspectiva bastante global, né, para o nosso debate de hoje. Muito obrigado, Diogo, pela condução desse painel.
Obrigado, Mark, e bom dia a todas e todos. Bom, meu nome é Diogo Alves, sou da Organização Pan-Americana da Saúde, no escritório que atua em Brasília. E agradeço a oportunidade de estar novamente aqui com tantos colegas aí discutindo esse assunto que é de tanta relevância não só para a organização, como também para o Brasil. E é interessante como os colegas que nos antecederam trouxeram várias informações do impacto das doenças crônicas não transmissíveis no Brasil, e os colegas que agora comporão o painel a seguir vão trazer não só os impactos, mas também a sua relação, de como ela é tão importante nesse movimento que nós estamos de recuperação da pandemia pós-Covid. E é claro, porque um componente dos sistemas de saúde foi sobremaneira impactado pela pandemia, e isso acabou impactando os pacientes, né, as pessoas que vivem com algum tipo de condição relacionada às doenças crônicas não transmissíveis. Então, rapidamente, eu tenho alguns dados aqui, como os colegas trouxeram dados nacionais, alguns dados que são globais, só para trazer o tamanho dessa dimensão e para instigar um pouquinho o debate que virá a seguir. Então, por exemplo, nós temos aí dentro das doenças crônicas esses hábitos de vida não saudáveis, que são condições que são modificáveis. Então, por exemplo, só o uso de tabaco já nos leva a 8 milhões de mortes anuais. O consumo e excesso de sal e sódio, por exemplo, mais 4 milhões de óbitos. E o consumo de álcool está relacionado a 3 milhões de óbitos. E ainda temos a parte de inatividade física, que também leva a óbito mais de 1,5 milhões de pessoas todos os anos. Então, é mais importante do que nunca, nesse momento de pós-pandemia, nesse momento de reflexão, de reconstrução, pensar na importância de como as políticas públicas para enfrentamento e controle das doenças crônicas não transmissíveis é importante. Então, eu peço licença aos colegas. I'm going to switch to English. Following, we are going to have 3 panelists here with us. We are going to have first Shekhar Potkar, and excuse me if I could pronounce your name correctly. And he's the current regional manager regional medical director of emerging markets and global NCD excellence at Viatris, and followed by Francesco Branca, who is currently the director of the Department of Nutrition and Health Eating of WHO. And our third panelist is Thomas Anker, and he is currently an investment director at the World Bank at the International Finance Corporation. So first, I would like to invite Shekhar Potkar to join us, and he's going to present us a presentation named "What has been the role of the private sector and strategic intersectoral partnership for building back better in NCDs prevention and care." Shekhar, you have 15 minutes. Please, the floor is yours.
Thank you very much. Thank you for the introductions, and I hope I'm audible. And let me share my screen. And very nice to see you online, Mark, again after a while. First of all, let me start by highlighting this is such a wonderful opportunity to be here with all of you today. Can you see my screen? Let me again confirm.
Yes,
Okay.
we can see.
So thank you for the opportunity to join this NCD forum, which is built around building back better, which is a very topical conversation that we are all having. I'm excited to join this esteemed panel with Mark and all the panelists that we have today. This is a very important conversation for us to discuss the role of private sector in the intersectoral partnerships and how can we play a role in building back better. So I'm going to talk about our experience from biopharmaceutical companies like Viatris. Let me start by providing you what we already know. This is a summary of the context. I think all of us are aware that we have witnessed or we are witnessing a deadly collision of non-communicable diseases and COVID-19 with significant consequences around health, around social economics, as well as the equity impact that we have seen in our part of the world. What it has done, it has exposed fault lines in the health systems around the world. And we really have become urgently aware that what we need, if we have to prevent the pandemics in the future, we need strong health systems, healthy workforce, a resilient workforce, and healthy populations. And this need is even more so in low and low middle income countries. That is our part of the world. At the same time, this pandemic has unleashed an opportunity, a crisis of opportunity. They say that every crisis leads to opportunity. So this is a crisis of opportunity. The opportunities, they cover a wide range of areas like innovation. We have witnessed innovation like never before. Drugs, biologics, vaccines. We have seen civil society engagement like never before. We have witnessed digital disruption. That's another huge opportunity that is lying ahead of us as we shape our future of how do we prevent the pandemics. And finally, there is a visibility of health in front of all stakeholders, the governments, the ministries of health, the civil society, the private sector. I think we have a clear visibility around health. So these are the opportunities that have been unleashed because of this deadly collision. Against this backdrop, if we were to look at what is the role that private sector organizations, especially the biopharmaceutical companies, can play. So I would want to frame this in three broad areas. There is a conventional role that biopharmaceutical organizations play, the role which is unleashed by the pandemic, the intersection of COVID and NCDs. Here, the role of connecting the dots becomes very important. And third, and the important one, which is because of the digital disruption and how do we leverage the digital disruption. So these are the three frames that I would want to talk about, giving some of the examples from Viatris perspectives. But before I go there, let me highlight the four principles that we believe in our experience. There are four principles that we want to undertake before we enter into any collaboration. When we enter into collaborations and the partnerships for building back better, our endeavor is to see if we can come up with solutions which are locally relevant. It is very important for us to solve the problems which are locally established. We have evidence. So evidence-based local solutions is the first start point. The second paradigm I would like to propose is the solutions need to be anchored around implementation science. We know a lot about NCDs and the solutions and the risk factors, but the outcomes still lag. And that is because primarily how do we address the implementation gaps from what we know versus what we see in terms of outcomes. So the solutions need to be anchored around implementation science. The third principle is we cannot do it alone. So we need stakeholder partnerships. We need subject matter experts. We need collaborators who share the passion, who share the cause. And finally, because of the pandemic, I think we have never before opportunity to reimagine and leapfrog. Not something we don't need to do it incrementally anymore. We can leapfrog on what we have already achieved because of the disruption caused by the pandemic. So these are the 4 principles. So let me then explain some of the examples that we have seen in these 3 broad areas. How is the private sector role changing over a period of time? I think, let me start with the conventional role. I think all of us are aware of the conventional role played by the biopharmaceutical organizations in medicines, drugs, biologics, vaccines. The biopharma also plays an important role in collaboration with the stakeholders, like medical societies, like the academic medical organizations, the technology companies in medical education. We also have an important role to bridge the gaps between the data and the evidence that we see, especially in low and middle income countries. And finally, there is an important role played by biopharma in providing clinical practice tools, the guidelines, the risk factor assessments, so the calculators that we have. So how do we improve the clinical practice? So these are the broad themes around which conventional biopharmaceutical collaborations have been in place. These all have a very important role to play in improving the NCD prevention and care and improving the outcomes. But what has pandemic done? The pandemic has really highlighted the connection between the NCDs and the COVID. We often call this a syndemic. And this is really providing us an opportunity for the private sector to connect the dots in policy, connect the dots in practice, and improving the patient outcomes. And here are some of the examples that we have seen. In terms of policy, I think we definitely have a role to substantiate the NCD investment case of how do we really create a strong business case for investments in NCDs. We collaborated with Defeat NCD very recently last year and highlighted of how the pandemic, every dollar that we have, the infrastructure that we have because of COVID, that can be leveraged for treating, preventing and caring for NCDs. So that was a report which was published by EIU, and that becomes a good base for us to really start using and shaping the policy. In terms of practice, we are entering into a strong pilot in one of our countries, South Africa, where we are establishing a syndemic action plan. And this is again an excellent example for us to really see, utilize the COVID infrastructure, the COVID testing, as well as COVID vaccination infrastructure for utilizing for NCD prevention and care. And finally, we have an example around patients. Because of the pandemic, the mental health is another area which is becoming substantially at the front and center. And how do we drive mental health solutions? So that's another area where we are able to connect the dots. Let me give the third pillar, the third theme of how the private sector collaborations are changing. And this can be explained if you look at the disruption in the form of a patient journey. We are all aware that the patient journey is typically in 5 steps: awareness, screening, diagnosis, treatment, and control. These are the 5 steps in patient journey. And there are a number of opportunities which are offered by digital because of the patient journey consideration. If you look at awareness and screening, we can definitely improve the awareness because taking advantage from the digital disruption, which is now we are all witnessing. We are collaborating with IAPO, the International Association of Patient Organizations, to establish Patient Academy, which will empower and enable patients to participate in the decision making. When you look at diagnosis and treatment, the other 2 pillars of a patient journey, we have a huge opportunity of improving the leakages which are happening from awareness to diagnosis. As an example, we see a substantial gap. Almost 1 in 3 patients who are hypertensive get diagnosed, and only 1 in 10 are controlled. And if we have to control that, if we have to manage this, we have an opportunity here. So telehealth, how can we leverage telehealth and telemedicine? And this is a pilot that we are doing in one of our countries, Thailand, to see how we can improve the diagnosis. And finally, how can we improve adherence? And here we can really leverage the enhanced awareness of the patients to see if we can provide nudges, utilize the principles of behavioral economics so that patients can stay on therapy much longer. So 1 in 10 patients who are controlled, that reality can change, and patients can stay on therapy much longer, and that can lead to improving patient outcomes. So these are just some of the examples from medical scientific perspective of how the private sector collaborations can change from the typical conventional model to connecting the dots and finally leading to leveraging the digital disruption. And this is all happening because of the realization that we need not view the crisis as crisis, but it can be viewed as an opportunity that we can leverage. So let me summarize what I have tried to articulate here. This is an unprecedented opportunity offered by the crisis. We are all aware that the 2030 NCD agenda, we are currently lagging, but we still can achieve it. And if we have to achieve it, it is still achievable. If we can invest in NCDs, and if we can really accelerate the progress by driving the key enablers. And the enablers in my presentation here, I've tried to articulate 2. One is connecting the dots, and second is how do we leverage the disruption. So I hope that gives you a frame from biopharmaceutical companies' perspective of what can be done if we have to play the role actively in driving the NCD prevention and control agenda. Thank you for the opportunity. Let me hand it over back.
Thank you, Shakar, for your presentation. It was very enlightening with very good ideas, and I would like to invite Francesco Branca to join us. Francesco, the floor is yours for your presentation.
Well, bom dia a todos e a todos, and thank you, Diogo, for introducing me, and thanks, Mark, for organizing this forum. I also have a presentation to share, and really the topic I'm going to cover today is the connection between food and non-communicable diseases, and then do we have any policy option for the response? So I'll really start by indicating that unhealthy diet and malnutrition are among the top risk factors for the global disease burden. You see, this is the number of deaths calculated by the Institute of Health Metrics and Evaluation. So these are the top risk factors. High blood pressure is really on the top, tobacco, but then the dietary risk you see comes sometimes second, sometimes third, but definitely responsible for a large number of deaths. And the latest estimate is about 8 million deaths. But food and nutrition are also having an impact on non-communicable diseases through obesity, a high body mass index, and through malnutrition. And this is basically additional 8 million deaths. And if you look at those components, you'll see that the dietary risk and the high BMI are really having an enormous impact on cardiovascular disease, on diabetes, and on cancer. I mean, these basically account for most of the deaths that are associated to the basically these risks. Now, if you go a bit more in detail in unhealthy diet, you'll see that, and this is the ranking we have. You see that diets high in sodium are probably the ones the risk factor that is responsible for most deaths. So you have excess consumption of sodium, you have excess consumption of sugar-sweetened beverages, you have excess consumption of processed meat and red meat, but you have a lot of insufficient consumption. So you have diet low in whole grains or fruits or vegetables or nuts that are also responsible for a large number of deaths. And on the left side of the panel, you can also see the difference between high and middle income countries and low and middle income countries. But you see that no countries is basically exempt from this dietary risk. So it is definitely a global issue. I would like also to add another element, which has been contributed a lot by research in Brazil, the work of Carlos Monteiro, and that is the issue of processing. So on the one hand, we have the components of the diet, so we have the nutrients, but on the other hand is also how the foods and nutrients are handled. So Carlos Monteiro has somehow classified foods into 4 groups. It said first group is foods which are minimally processed or unprocessed, like the milk, fish, fruit, vegetables. The second group is the processed culinary ingredients. So these are substances that are derived from this first group and then are used as ingredients for preparations. And you have, for example, oil or butter or honey, and there's some element of processing, but these foods are used as a component of preparation. Then the third one is processed foods. And this is really the outcome of processing, for example, cheese or meat or canned fish or wine and bread, of course. So these are mainly made of ingredients from group 1 and group 2. But then there's a fourth group, which is called ultra-processed food. That includes sugar-sweetened beverages, certain ice creams, drinks, certain manufactured pizzas that have the characteristics of being produced from a combination of basic elements that are derived from group 1, but have very little to do with group 1. And as you know, there are some staples, for example, maize, that can be used to extract a number of sub-products, which are then recomposed to make ultra-processed food. So basically, this classification is looking at different degrees of processing. The different countries in the world have different degrees of consumption of ultra-processed food. There's a classification that has been developed, the NOVA classification, that allows this estimate. And you see that countries like the United States consume most of their food from this kind of products, whereas in other countries, such as, for example, some of the European countries, this is much less consumed. Latin America is a little bit in between. This is also a transition which is changing very quickly. Now, there's been an association with the consumption of ultra-processed foods and different entities. In this case, you see there's an association with obesity. Doesn't seem necessarily going in the right direction. But if you, for example, look at within a country, so this is the case of Canada, you see that by dividing the population in terms of their quintiles of consumption of ultra-processed food, you see really a graded increase, for example, in this case of obesity. So there is a predicted adjusted odd ratio of obesity across quintiles of ultra-processed food consumption that really increases. So you have about a 30% increased rate of obesity in groups of population that consume a higher proportion of ultra-processed food. So ultra-processed foods are now being looked at with an increased interest, really as an additional component on its own of risk for non-communicable diseases. WHO has been developing and updating its definition of a healthy diet, which is globally relevant. We need to come with common elements that might be helpful in all circumstances. And the objective of a healthy diet is really to have optimal human growth and development, but also prevent malnutrition in all its forms. And we need to remember there are multiple forms of malnutrition. Even the Sustainable Development Goals speak about all forms of malnutrition. We include, let's say, 3 groups of deficient of malnutrition, 3 elements of malnutrition. The first one is undernutrition, so wasting, stunting. Second one is inadequate level of vitamins and minerals, so micronutrient deficiencies. And the third one is obesity. which with its comorbidities and its outcome on diet-related non-communicable diseases. So we need to have a diet which is able to address all these conditions in all circumstances. And our recommendation should really aim at addressing all these forms of malnutrition concurrently. So we shouldn't have, a diet for undernutrition and then a diet for NCD risk, and they have to be simultaneous. And it's possible, and by looking at different approaches, by considering different approaches to come up with this definition, we end up, systematically with the same set of elements. The first one is around plant foods and having a large component of the diet coming from fruit, vegetables, legumes, nuts, whole grains. Then having at least 400 grams of fruit and vegetables per day. This is excluding the roots and tubers. Having less than 10% of total energy intake from free sugars, less than 30% of total energy from fats, and having plant fats, unsaturated fats, more than saturated fats and trans fat of all kinds. Having less than 5 grams of salt per day, and drinking safe tap water. Now, this diet happens to be also very useful to minimize the environmental impact. And this is a graph from a recent publication that WHO developed with FAO. So you see in the first part, you see the components of the diet that maximize health. The second part is, how this diet is really able to reduce greenhouse gas emissions, preserve biodiversity, minimize the use of antibiotics and hormones in food production, minimize the use of pesticides, but also packaging materials. But it's also a diet which is appealing from the point of view of the culture, and also more equitable. Now, the problem is that this diet is not necessarily affordable to all. So we calculate that about 3 billion people in the world cannot afford these diets, which are the kind of ideal diets we would like to receive. So how do we handle that? Last year, there was a UN summit, the UN Food System Summit, that brought the food system transformation high up in the political agenda. And WHO developed a series of recommendations of effective policies. We're actually now also calculating the cost effectiveness. And so we're saying that that these policies are not only cost effective, but also affordable to low income countries. So they are what we call the best buys. And as you know, there is a list of best buys for non-communicable disease prevention. So we are updating that list, and these policies should most likely feature in that list. So these policies are particularly looking at the food environment. The first one is for reformulation of manufactured product with less salt, less sugars, and less unhealthy fats. And having more nutritious component, particularly the whole meal grains and the nuts. The second one is about price policies, which would increase the cost of unhealthy products and subsidize healthy options. The third one is public food procurements. So basically allowing people that are having food in public institutions such as schools, hospitals, government canteens to have access to healthy diet. And this is also important because it would drive the whole food system to produce foods which are the ones that we would like to see in a healthy diet. Just only the city of New York buys several million meals every day. So it's just to give you an idea of the value and the impact of these policies. Fourth one is about clear messages for consumers to make their choices through front of the pack labeling. We know that in Latin America, there's been a very successful use of warning labels, as in Chile and Mexico, communicating to people that certain products should be consumed in much lower amounts. Fifth important policy is the policy of fortification, addition back of vitamins and minerals, particularly through the staples that, such as cereals, that have been processed in a way that these nutrients have been removed. And finally, but probably one of the most important, is regulations that curb marketing of products, particularly to children, that are high in fat, sugar, and salt. So these policy options, we believe, are going to be important game changers for the transformation of the food system. The status of the art is that we only have these policies applied in some countries. Sugar sweetened beverage taxes, we have counted 79. Not all of them are, however, done in the way that is really capable of making substantial changes in consumption level. We believe that at least 20% of the value of the product should be taxed. Food product reformulation, you see 60 countries, basically a third of the old countries in the world. Front of the pack labeling initiative, only about 20% of the countries. Public food procurement is a more interesting one. More countries are doing that. Fortification, I think we're doing well with salt iodization, a bit less well with wheat flour fortification, and the marketing restriction are really only applied in about a fourth of the countries in the world. So there's quite a lot to do. So I hope that we can all have collaborations and strong advocacy for the implementation of this policy. So thank you very much for your attention.
Thank you, Francesca, for your very good presentation and bringing to the public how the organization is working with the member state, offering policy options to curb this health challenge. So for our third speaker, I would like to invite Thomas. Thomas, the floor is yours.
So very good morning, everybody. Thank you so much for the invitation. Thank you, Mark, for being nice and and inviting me here. I also have a presentation to share with you, if you don't mind. I hope you guys are looking at my presentation. Can you see my presentation? Yeah.
Yes.
So So the idea today is to speak about something that I've been working for some years now, which is public-private partnerships in health, especially related to a program that we are developing here jointly with BNDES. I'm part of the IFC, a World Bank arm, but we have a partnership with BNDES, the local development bank, and IDB. It's a program to foster PPPs in Brazilian municipalities by means of primary health care. The question that was posed to me was why and how partnerships between sectors and private and public sectors can really show positive outcomes to solve the NCD issues and lessons to be replicated. So that's why I decided to speak here about partnerships, which is the core of my work. So this is, a little bit of the outline that I prepared for this presentation. I hope that I have time for the very first part would be to speak very loudly about the healthcare challenges that we see and why IFC and this group is involved into the making of PPPs and trying to bring the private sector into healthcare issues. Then I'm going to try to put everybody to the same page of what a health PPP is and what it means for the countries. Then I'm going to go specific into a study that we've been conducting jointly with BNDES for fostering primary healthcare PPPs and the business model that we prepared and we want to escalate in Brazilian municipalities. And then I'll speak a little bit about some of the market perceptions that we were able to collect throughout this study, and then show you where we are in terms of this pilot program. So I really like this very first this slide, because it shows the ideas of why I see and why this group is involved in health, why health is important for us. First, there's the growth angle. Of course, 1 extra year of life generates more GDP. There's a study that shows that 1 extra year of life can generate an increase of about 4% in GDP. There's the social development angle. For instance, in China, 0.1% decline in the maternal mortality rate, showed to have a correlation with the reduction of female illiteracy. There's, also the productivity angle. The same study showed that when you have better health, you can improve. You can have more than 33 million productive life years, which are now drained due to cardiovascular diseases. We can, generate more jobs. 40 million new jobs expected to be crafted until 2030 by means of healthcare. There's also a very important effect in terms of demographics. When you have a better healthcare, you don't have the burden of elder care being only on women. So you see the relationship and the correlation between that and the reduction in women's work hours by around 40%. And lastly, when you have very important healthcare investments, this is also associated with a higher level of foreign direct investment. So this is all the angles that we see and why we think it's very important to be involved in the healthcare sector. Again, speaking a little bit about our mission, why we think that we need to foster private sector, the private sector role in healthcare. I think that there are 3 basic buckets that we have to think here. First is to really increase the access to basic health services, which is currently very limited. So we do think that the private sector has a good role to play in terms of providing higher access to affordable quality healthcare. Second, if we look at the numbers, there's an enormous gap in terms of investment needs. There's this Untitled study as of 2019 that shows that there's investment need of $200 billion to really be able to meet the SDG 3. As of today, we have investments levels of around $70 billion. So there's a huge gap to be taken, and we think that the private sector has a good role to play here, of around 40% of the total annual investment needed that can come from the private sector. And thirdly, of course, the governments worldwide, it's not only Brazil, but worldwide, it really has a very tight fiscal space. We have a macroeconomic condition which leads to rising debt burdens. So, and at the same time, we have governments competing for resources and having competing priorities. So again, it's very important for the private sector to come in and to provide private financing for meeting these goals. Especially regarding non-communicable diseases, we have the statistics that show that NCDs account for almost 70% of deaths in low-income countries and middle-income countries. At the same time, these diseases are only receiving 1% of the development assistance. So, it's unproportional to the number of deaths that NCDs cost. So again, just to make the point, the private sector has a lot of roles to play here to meet the gap, either in terms of financing and also in terms of expertise. Just to finalize here, the roadmap to SDG 3. So SDG 3, as you may know, is to ensure healthy lives and promote well-being. So again, showing the study of UNCTAD, showing that there's a need of $210 billion up to 2030. And there's additional possible private investment of 70 billion to really meet this gap up to 2030. And how we can come up with these numbers. First, we do have to enable the environment for private sector. We have to, I mean, I'm speaking very loudly, but we have to strengthen the regulatory regimes. We have to improve planning, and we have to set standards to facilitate private sector investments. We have, of course, to widen insurance coverage to promote more affordability in countries, especially for low income and rural populations. In terms of private sector engagement, we have to enable tools for private sector participation, such as PPPs, such as outsourcing or specific services, such as medical waste, pathology, et cetera, And the fourth part of this roadmap is to really create the market, create the opportunities, lead initiatives and investments that can really foster innovation, can foster competition, can have demonstration effect to the private sector, and then can be replicated in countries all over the world. So now speaking very, very shortly about what a PPP is, and not speaking necessarily only about healthcare PPP. I'm speaking about infrastructure, core and I would say social infrastructure, as we call in the literature. What are the objectives and advantages of PPPs? First, we have a wider access of sources of financing, not only public financing, but also private financing. And there are many ways, many tools to have this financing be attracted to these opportunities or to these operations. We can, by means of PPPs, we can have access to better industry practices. We can improve the quality and services standards by means of an output-based contracts, and not really necessarily input-based contracts, by means of KPIs, by means of incentives-based contracts with governments. We can, of course, we try to really put governments into the focus of designing policy, designing planning and regulation, not really operating the equipment, and not really operating the healthcare facilities. We can also, of course, generate more predictable and long-term budget commitments. And lastly, I think that one thing is very important over the long run is to generate value for money. When you do contracts, when you do agreements that can generate a competitive bidding process and can adequate risks between private and the public sectors in a very adequate manner in the long run, by means of well structured PPP agreements. So this is also very important. In terms of healthcare designs, this is the spectrum of healthcare PPP models that we can see in the world. This can come from more simplistic types of PPP, such as management contracts, where you still have lots of public sector responsibility, not too much of private sector responsibility. And then you can go up to a higher degree of complexity, such as integrated PPPs, where you have the whole set of scopes in a healthcare PPP being transferred out to a private sector, where you have a higher degree of complexity and a higher level of private sector responsibility. But in between, you have a long array of possibilities of transferring these responsibilities. Just to be now coming to the bulk of my presentation here, this is the study that we've been conducting with BNDES in this PSP infra for over 1 year now, which is, we started off by being kind of ignited by the Brazilian Investments Partnership, which is a federal government entity, on why there's not so much PPPs in the Brazilian public primary healthcare located to pertaining to the SUS, to the Brazilian healthcare system. And indeed, when you look at the statistics, there are not very many not very many cases in the public healthcare domain. So we prepared this, in these institutions, an improved methodological framework to really understand how to better engage private sector in the segment, especially in the primary healthcare segment. We do have, as institutions, we do have a good understanding of financing of healthcare providers, but not really in the design of PPP. So we really wanted to stimulate that market to happen, especially in Brazil. But having said so, we participated in some of the very first healthcare PPPs in the country in the past. So we designed the very first emergency hospital PPP in the country, in the state of Salvador, back in 2012. It's almost 300 emergency hospitals PPP. It's an open doors hospital PPP linked to the SUS, to the Brazilian healthcare system. Was won by a consortium and is currently operated by a French Brazilian consortium company, and it's basic. Here's an integrated PPP. It's clinical and non-clinical services being implemented and being operated by this consortium. We also have been engaged in imaging diagnostics PPP, the very first in the country, also with the state of Bahia, taking into account the telemedicine and teleradiology systems that technology provides for. It's a consortia that is composed by Alier, a medical provider here in Brazil, Philips, which is a vendor, and Fiji, also another Brazilian company. The idea here is to provide reports, radiology reports to 12 hospitals spread out over the state of Bahia, with radiologists being centered in the capital city in Salvador, and really providing the reports, providing the tests to these 12 hospital wards over Brazil. And then the only primary healthcare PPP, which is located in the city of Belo Horizonte, it's also a project was designed by us. It's a PPP, a healthcare PPP, PFI as we call it. So it's not really integrated services PPP. It's only for non-core services for 77 new healthcare units spread out in that municipality. So just to show you some of the experience that we have already. So it's not really something new. It's already happening. What we want is to replicate. So this is another stories that we have developed in the world. So we have experiences in Turkey for 30 plus health campuses. In Turkey, we have also designed the new Bossa Hospital as a PPP in Colombia. It's the very first in Colombia. 25 pathology, 25 radiology centers in India, and the one that I just explained, the Bahia Imaging Diagnostics in Brazil. So we have experiences not only in Brazil, in other places already functioning. So now coming to the study, this is the study that we developed jointly with BNDES to really assess the gaps and issues faced by the improved provision of services in primary healthcare services in Brazil, to really be able to attract more private sector participation in primary healthcare. So the idea was to propose a PPP model that could be feasible for municipalities and at the same time scalable for a wider range of municipalities in Brazil. We came to some conclusions. First, the first outcome in primary healthcare is that child mortality rate, as you may know, we have as of 2019, 14 mortality rate of 14 over 1,000 babies born alive. So this puts Brazil into the 81st global rank position. So I mean, there was a lot of progression over the years, but we are still far from reaching our goals. In terms of coverage in primary healthcare, we want to achieve universalization. So we're currently around 65%. So there's still, again, there was lots of progress being done in the past, but we're still far from 100%. At the same time, there's a census that shows that there's lots of infrastructure needs in basic healthcare units. 50% of the whole network of basic healthcare units in Brazil requires some type of retrofitting or some type of reform. And at the same time, when we look at the clinical ratio, the clinical production is still low. Efficiency is still low as compared to other countries in terms of consultations, in terms of procedures. Of course, we have a good ratio in terms of doctors per 1,000 inhabitants, but we are still far from nurses over 1,000 inhabitants if we compare with other countries. And this has, and also we have an access issue with to provide better diagnostics, lots of unmet demand for basic diagnostics, which has a lot to do with the lack of internet band and internet technology in 50. We don't have internet band in 50% of the municipalities in Brazil. So still far from the basics, right? And so this makes us spending around 40% of GDP, which is still a low level as compared to OECD countries or middle income countries, according to a survey by IBGE. So we started looking at the experiences. Again, I don't want to go too much into detail because I don't have time, but we have infra experiences. We have primary care PPPs. And I think that the most important experience and kind of role model here would be the so-called NHS lift, which is in the UK. We have services PPP. We look at experience in Rwanda. We also looked at walk-in centers in NHS. And I think that the most known experience of an integrated PPP, although we have ours in Brazil, is the Alzira PPP in Spain, which has the whole spectrum of PPPs, and a capitation model was transferred out to a private sector. I don't want to. I'm going to go again now to the model. So this is the model that we are proposing in this study. First is to have, we have a high, an angle here for new construction of basic care basic care units in Brazil, or retrofitting. The idea is to also have a municipal diagnostic center to be implemented by these municipalities, and also take into account the new regulations in Brazil regarding telemedicine and teleradiology, is to have a municipal telemedicine platform in these municipalities, and this can be modulated and can be escalated to the wide array of municipalities that we have in Brazil. This is a little bit of the scope. Basically, a private will again, be basically related to civil works, to the management of this municipal diagnostic center, to I would say facility management services provision, and the public would remain with HR management and with the management of this clinical services over the long run. So we, as part of the study, we went to the market to really try to get a sense and to get a feedback of what these ideas meant for the market. So the conclusions are that first, the market is there. Obviously, we have to look at the modeling features, but the market is there. It's really, there's an appetite for this type of business case. In Brazil, we still have ideological position, but it's much better than we had in the past. And I think that communications is very important to make these ideas come through. Scale and efficiency are really key. The high number of covered units and test exams are really important for the private sector to make it viable. Of course, HR management is very key. So we still have to think on how to really involve HR into the private sector responsibility. I don't have to say that the use of technology and data integration is even, is each day more important, and is very, very key to have an improvement in the regulatory framework, especially regarding public guarantees, since we're speaking about long-term contracts with the private sector. So public guarantee scheme, public guarantees is key, and payment systems is also very important in this equation. So this is the program that we are doing now with 5 Brazilian municipalities. We have already 2 signed, 1 being signed very, very soon. So we have 3 already in the pipeline. We are, ICNBNS is coordinating this effort. It's a pilot program. We have technical consultants already hired, and this is going to take 14 months until the project goes to the market. So that's it. Thank you very much. So you're on mute.
Thank you, Thomas. Thank you also to advise me. Your presentation was very clear how partnerships are important to health challenges. So just recap, Shakar told us about how the pandemic brought us the idea of resilient health systems, health population, investment on human resources, and the engagement of non-state actors. And he also brought some recommendations regarding, for example, evidence-based locally solution, health innovation, for example, science, diagnostics, treatment, control, and telemedicine. And he brought a very good positive message that the 2030 agenda on NCDs is achievable. Francesco told us about the burden of unhealthy foods, how foods and nutrients are handled, the problem with ultra-processed food, obesity, undernutrition, micronutrient deficiency, and leading to several other health conditions and diseases. But he also brought us some very good ideas and policy options, for example, of the sustainable health diets, the WHO policy options such as the reformulation of products, price policies, public food procurement, the front pack labeling, and fortifying foods and market regulation. And our third panelist, Thomas, brought very good aspects on how health could positive impact the sustainable development, the importance of partnership to control NCDs, and the need of clear rules of engagement. And he also enlightened us with some examples in Brazil, in the state of Bahia, Amazonas, and Minas Gerais. And he also brought very good ideas by the end of this methodological framework aiming to strengthen the universal health system in Brazil, the SUS, and how it could improve the government to access gap and attract investment, especially on primary healthcare resolution capacity. So now we are going to have a debate where the chat is open for anyone who would like to pose a question. And I can see that we have already one question from Yara, I think. The first question is from Yara. Just 1 second. Here it is, to Thomas. PPP is always very welcome, but in the health sector, there is a fine line sometimes that can be interpreted as a possible conflict of interest. It is clear that we may be missing out and many opportunities here, which could have been avoided perhaps with well-defined partnership models, etc. So my question is, based on your experience, how could we deal with this issue?
Yeah, should I answer now, Diogo?
Yes, and then I'm going to keep
all right.
Posting the questions, please.
All right, thanks, you. Thank you for the question, Yara. I think that you put a very, very, very important question, because we are, differently from other infrastructure sectors and differently from other PPPs and concessions that we have, for instance, in roads, in airports. Here we're speaking about human lives. So we have to be very, very careful when communicating to the society, communicating with governments, communicating with investors. So I think that the key for doing that is to, first of all, is to have very good contracts and very good, as we call, performance indicators, clinical indicators, non-clinical indicators in these agreements. We have to discuss with society. So when we are doing PPPs in Brazil, we have to have public consultations. We have to do market soundings. We have to speak with the social control, as we call here in the SUS. We have to speak with society to really understand what would be the best, the most critical needs of society, and try to negotiate as much as possible. Because the demand for health in Brazil, we know is tremendous, but we have to negotiate what is priority. So I think that the key here would be really to use the embedding environment to try as much as possible to be transparent and speak with society and bring society into the making and the crafting of a PPP agreement in healthcare over the long run.
Thank you, Thomas. And in the same line, I would like to address the same question to Shakar regarding your experience and how we can deal with this issue.
Yeah, thank you, Diego. I think this is a very important question. We have, over the last few years, entered into more than 100 such collaborations across low and middle income countries in different facets of non-communicable disease area. And what we have learned, I think there are a few fundamental principles which I outlined in my initial talk. First of all, between partners, we need to really clearly align on what is the problem that we are trying to solve, the issue to be solved, and what is the evidence from a solution perspective that we are trying to come up with. So clear alignment on the problem to be solved and the evidence-based approach is something which works very clearly. We need to have an approach which is also anchored around implementation science. So I think these are some of the fundamental principles we have followed. And the third part, which I think very clearly Thomas outlined, was the governance, which is an important facet as well. Are we able to have a clear, transparent governance between the public sector and the private sector on what is the outcome, what are the milestones, and how do we really assess the performance indicators or the success? I think that is equally important for us to really put that in place ad hoc, before we start, and not as an ad hoc or subsequently. I think this is an also equally important consideration. So these are a couple of considerations I would really suggest to add to the success of a PPP.
Thank you, Shakar. So my next question goes to Francisco Branca. In the first panel, Patricia Vasconcelos from the Ministry of Health presented that young people present poor food consumption than other older individuals in Brazil. What policies would you recommend to change this scenario?
Thank you very much. It's a very interesting question. And clearly the first point is, why is that the case? So this is really a demonstration of the power of food transformation. So the food system have been evolving, and definitely processed food are occupying a greater space in our diets. And marketing has a big responsibility for that change. So certain processed food are really described as innovative, as modern, as more appealing from the point of view of the taste, also more easily accessible, often cheaper. And marketing is not just the advertisement. You have the 5 P's, product, price, promotion, place, and people. So everything is designed to make those products appealing for the younger people. So that's why the policies to control marketing food to children are so important. But that's only one element. We also have, this is not only about prohibition. This is about suggesting a food culture which is associated to health, but is also associated to the protection of the planet. So we need to have, movements which are appealing to young people for foods which is healthy and comes from sustainable food system, and using the same, in a sense, using the same tools. I mean, we cannot have a healthy diet which is more expensive than a non-healthy diet. I mean, that's a paradox. So there must be some, investment, public and private investment to make that happen. And then it's about the offer of food. I mean, you go in every petrol station, what do you find? You go in every corner, in every station, what do you find? I mean, the availability of the healthier products needs to improve. So we need to use what we call the nudges to make people choose the right food. I mean, if you go in a machine that distributes food product, what you find? You find always products high in fat, sugar, and salt. But you actually have the healthier alternatives, which are also convenient. So we need to use that. And finally, I think the aspect of reformulation is important, because it's true that I think it's going to be very difficult to reverse completely the use of processed food. So let's try to at least have processed food which is a better formulation. There's no need to have that much sugar in processed food. There's no need to have that much salt. They're still going to be palatable foods. And this has to start very early in life. Can you find easily a yogurt which has no sugar for children? You can't. So we need to start with that exposure to foods much earlier in life. So foods, particularly the ones designed for children, what we call the complementary food, should not have the amount of sugar that it's there at the moment. So that will also help a shift in the habits of the population. And then, of course, for the older people have the strength of the culture. I mean, the traditional food culture is so important. It's so meaningful. And I think it would be still important to have that value of identity of the food culture in a country like Brazil. Also, the way, I mean, Brazil has dietary guidelines, for example, talks about the way you eat food. So not only about the food itself, but it's also having meals as a social habit, not having foods while you're outside and walk, but really have dedicated time. So these cultural aspects, which are probably more, let's say, appealing for the older generation, might come back for the younger generation. I mean, marketing people should work for health, not against health.
Thank you, Francisco. Yeah, Brazil is a very good laboratory for that, and we are developing some very good examples here. And you told that it's very important not only to raise awareness, but also to offer healthy options to the population. And we also have the guidelines on the Brazilian diet. So it's very good, because then you can act locally and you can also promote the local producers. So just I have just one question to Thomas, and I'm going to put another one here because it's really very important, this question. Globally, we have other health matters attracting more private funding to NCDs. In Brazil, even less. So what are your recommendations to make NCDs more attractive to private funders or donors? And also this one here, that what are the main barriers that you faced when you proposed these standards to the Brazilian government, to the Brazilian market? So please, Thomas.
I'm gonna start by the second one, which I think is simpler. I think that we are still proposing for municipalities, and although there was lots of progress over the, I would say, 10 to 15 years where we had the very first PPP implemented in the country, and you have, for instance, in some governments, you have already the OS, the social organization. So the culture of having private sector embedded in the public, in the schools, in the universal system is already there. I would say that there's still lots of resistance over the idea of having private sector in the making and in the delivery of healthcare solutions. So I think that if I got correctly, the first question was what would be the main bottleneck or the main issues to really have more of those experiences in Brazil. I would say that the first is still, I would say sort of an ideological barrier to have private sector involved, with the aim of having better services and measurable better services, evidence-based, as Shekhar was mentioning before. And the second question, I think, is related to how to make NCDs more appealing to financing. I would say that you have to, the more visible, the more awareness and the more advocacy we do, and the more we try to speak the language of private sector, the better, with guarantees, with the regulatory regimes, with rule of law. So there are many angles by which we could try to enable more funding for NSDs, but it's like doing an investment, right? You have to have a certain angles in the house to make it more appealing to private sector. So, yeah, thank you.
Thank you, Thomas. Shekhar, I saw you raise your hand in the previous question, so perhaps you would like to complement.
Yes, I wanted to supplement an excellent response from Francisco on the previous question around the nudges, how we can make it attractive from a food perspective, the food policies. I just wanted to add that fundamentally we need to start looking at principles of behavioral economics in decision making, because even though we may know things, but we do not necessarily implement, and that is human behavior. And this is exactly what we see across the non-communicable diseases. It is seen in food, it is seen in obesity, diabetes, cardiovascular, across the range of conditions. If we can improve the behavior by applying the principles, by improving the choices that the people make, by providing them incentives and by providing them punishments, it is a choice architecture that we need to really modulate. And that is where I think we have the nudge theory, which will be phenomenal in application if we were to apply for improving the patient outcomes. But this is just to supplement what Francisco already mentioned in his response.
Very good words, because now I have one final questions to Francesco, and has to do with your comments here. Francesco, how can we improve this kind of policies in a world in that food industry is so strong and food policies in Brazil are very weakened?
Well, it's a very important question. I mean, particularly in a conversation today where we're talking about the value of public-private partnership, and clearly, of course, we're talking about different kinds of private sector, and there is perhaps a different risk of their engagement according to the nature of the service they provide. And I think Brazil has actually an interesting experience of using a tool which WHO has developed to assess conflict of interest. And the approach is really risk assessment. So it's not black and white. It's sort of the engagement with food producers and distributors depends on the nature of the actor, but also depends on the objective of the collaboration. And it is possible to assess this risk and then have adequate measures to protect against conflict of interest. Clearly, when it comes to regulatory policies, that engagement becomes more difficult. But it's still possible to hear the position of the companies, as it has happened, for example, in many countries that we're looking at front of the pack labeling. You hear from them, but they don't necessarily, sit at the table of the decision making. That would be, of course, seen and probably would practically be a conflict of interest. So risk assessment approach is an important one in terms of the engagement. Now, we are aware that certain policies are actively objective. I mean, the ones that I mentioned in my presentation are often actively objected by the companies, because that would, change. That would lead to a change in the consumption of certain products, and therefore a change in their sales. But companies would have to adjust their companies' corporate policies to align to health objectives. So I think we need to accept that there is a problem there. We need to accept that we need to be very transparent about the engagement and avoid conflict of interest. But also we need a strong civil society, because the strong civil society might demand for policies and also monitor the implementation. We have very good example. I mean, the very difficult discussion around taxation of sugar-sweetened beverages in Mexico, for example, was initiated by a strong civil society campaign. And unless we have a strong civil society, it's difficult also to have a balanced engagement where conflict of interest is actively monitored, not just by the government officials, but by the society. So transparency, engagement of civil society, I think these are important elements. But we need to acknowledge it's a difficult engagement, if not difficult fight.
Thank you, Francesco. So as we are proceeding to the final moment of this international panel, I would like to give the floor to you to some close words, close remarks. So let's follow the same order of the presentation. First, Shakar, I would like to give the floor to you. Please, is yours.
Thank you, Diego. I think this has been an absolutely interesting and very, very provocative, important discussion for us to have. How do we build back better? I just want to reiterate what we discussed. I think it is very much within our reach. We have 8 years to reach 2030 target of NCD goals, SDG. And there is a lot that needs to be done. If we will need to step up and accelerate the efforts which are going on. And for that, everybody has to come together. I think all the stakeholders need to come together with a clear agenda. I think we have seen the NCD investment case with the clear ROI. 19:1 is the net ROI that we are talking about. For every dollar invested, we probably will have 19-fold impact. And if that is the case that we are talking about, I think it is only only imperative that all stakeholders come together with clear agenda and with the clear solutions that have local relevance. I just want to reiterate that and really appreciate the opportunity to participate in this esteemed panel. Thank you.
Thank you, Shakar, for your words, and also to your presence to this very important debate. And now I would like to give the floor to Francesco Branca.
Thank you, and also I'd like to share the views of Shekar. This has been a lively, interesting debate. I personally have learned a lot from the colleagues that come from the investment side. But really, my final message is that food system transformation is needed, cannot be delayed. Business as usual is not an option. And I'd like to use the same slogan. We can build back better after the pandemic. Now the pandemic is followed by a war, so the system has to be transformed. I mean, that the war has actually generated a food security crisis. So how can we, think of feeding the whole world population is going to get 10 to 10 billion in 2050 with this dysfunctional food system? Simply not possible. So we need to have a change in food system. We need to have a recovery of a food system which is so heavily affected. It needs to be green and healthy. And we definitely need to have these objectives about health for the people and health for the planet, which are not incompatible with prosperity. They are compatible with prosperity. In fact, they are. I mean, as Thomas was saying, the healthier and the better lives, even the greater income. So let's try to, have this really as the agenda for the next century.
Thank you, Francesca, for your words, and also for this final call for action for the public here and for our partners in Brazil. And please, Thomas, the floor is yours.
Oh, thank you very much. It was I appreciate very much for the learnings that I had with Shekar and Francesca this morning. Was really, really, very, very good for my own knowledge here I learned a lot. Thank you, Diogo and Mark for the invitation. And my final message here is to deal with the role of PPP, with the roles of private sector and with the roles of PPPs. I think that we'll have to demystify a little bit the tools there, not only in Brazil but in other places. We have to really understand better the tool and see how we can best adapt them to primary healthcare, to emergency healthcare, to many angles in healthcare, the needed healthcare in the world. So my final message is that the real importance of private sector to really achieve the SDG 3 by 2030, as Shekar was mentioning. Thank you so much.
Thank you, Thomas. Thank you to you all. I believe that your words, your recommendations, our arguments will be very useful for the following panels that are coming, so people can reflect and react to all those ideas. Thank you again for your presence here, for your time, and I would like to give back the floor to Mark Baroni. Thank you.
Thank you very much. Thank to all our panelists and also to you, Diogo, for the conduction of this so rich and interesting panel with perspectives from the different